Dear future dentists, welcome to Department of Propedeutic of Internal Diseases again. In my opinion, the most fascinating aspect of our subject is diagnostics of what has happened to a patient's internal organs. That's a riddle of the vast majority. This aspect is often called clinical thinking. Therefore, we can interpret the notion think like a doctor as apply the laws of formal logic within the context of medical practice. That's true either for internal medicine or for dentistry too. The wish to know what's yet unknown is a characteristic trait of human mind. And this is why there lives in every good doctor a little Sherlock Holmes, a house MD, or a mentalist. But to be able to realize clinical thinking in real practice, any future medical worker must have a good base from theoretical disciplines. They are not over yet, but you have plenty of them in your history. By the way, does it mean anamnesis morbi or vita? Of course, anamnesis vita, if we recollect our previous lecture devoted by the chapters of case history report. So let's return to clinical thinking, the ability to think as a doctor. The good background for it is such sphere as the diagnostical methods. The wider is this area in doctor's mind, the better and the widest choice of appropriate method, the shorter the way between first opinion about pathology, for example, kidney disease, and final grounding of diagnosis after all the necessary investigations. We discussed imaging studies, lab studies, procedures in CVS, cardiovascular system disorders, and respiratory one. And this is turn off kidney diseases. I know you have passed anatomy with a great success, and physiology was learned too. But for any case, I'd like to key point of kidney morphology. It'll make your life easy in context with the future discussion of renal pathology. So some minutes to recollect the kidney, nephron, anatomy and physiology.
Nephron. Kidneys function as the excretory organ in vertebrates and humans. The kidneys are found in the back of the abdomen cavity and on both sides of the lower back spine. From outside in, it consists of three parts: renal cortex, renal medulla and renal pelvis. When microscopically examined, it is seen that kidney is made up of structures called a nephron. Nephrons are the building units of kidney and function as filtering units. Bowman's capsule is found at the beginning part of the nephron. The Bowman's capsule consists of a single layer of epithelial tissue which completely covers the glomerular capillaries. The glomerulus is a network of capillaries which fill the Bowman's capsule. The afferent arterioli entering the Bowman's capsule branch out into the glomeruli capillaries. These capillaries merge together and exit the Bowman's capsule as efferent arterioles. The structure formed by the Bowman's capsule and the glomerulus capillaries are called Malpighian corpuscle. After the Bowman's capsule is the section of the nephron tubule called the proximal tubule. This structure is located in the cortex of kidney. The proximal tubule leads to the loop of Henle in the medulla region of the kidney. The loop of Henle is made of two parts, as the descending limb and the ascending limb. The loop of Henle ascends back into the cortex to form distal tubule. The distal tubule then connects to a wider tube called the collecting duct. While malpighian corpuscle and proximal tube parts of the nephron are found in the cortex, the loop of Henle is located in the medulla region.
Well, let's continue with the diagnostics of kidney disease. Such words were pronounced quite 200 years before. In case of the fatal outcome, the pathologist has at his disposal the body. While the patient is alive, the doctor may investigate his urine. It was pronounced by famous Richard Bright, but that's actual till today. Let's check it with me. So, in general, all the pathology of kidney can be divided into two main groups: glomerulopathies with predominant and primary damage of glomerula, and tubulopathies correspondingly. The classical name for pathology with primary involvement of glomerula is glomerulopathy or glomerulonephritis by old nomenclature, and correspondingly the good example of tubulopathy is pyelonephritis. Besides these independent nosological forms, glomerulopathy can complicate another system disease. Look, I meant that either glomerulopathy is the only and primary developed in glomerular pathology, or it can be syndrome in frame of more systemic disease, such as systemic, you see, the same word, this pathology illustrates my thought. So, systemic lupus erythematosus can be manifest with a glomerulopathy too, or, for example, in diabetes mellitus, kidney will be involved. And this problem connected with glomerular damage again. By other words, the pathology in kidney is the only main problem with first step develop disease at the level of glomeruli, or this is a syndrome, of systemic disorder. Tubulopathy can be induced in our epoch of polypragmasia, usage of plenty of drugs by one patient. So let's discuss history in some words. The urine analysis was described by Hippocrates in connection with the presence of bubbles at the surface of urine. He connected the presence of such abnormalities, not abnormalities, of course, bubbles. It was described in 5th century BC with a prolonged course of any renal disease. It was maybe the first link to the renal pathology accompanied by problems with in urine. Then later, term proteinuria was appeared, but only 2 centuries before, and Richard Bright proved connection between proteinuria, the excretion of large amount of proteins with the urine, and pathology of kidneys. It was performed less than 2 centuries before. You see? So, what's a principle to be considered before we'll start detailized diagnostical methods? There are a lot of causes of renal disorders, but if any clinical manifestations, symptoms, and signs are of a limited value, and lab study is very informative due to impossibility to guess what's wrong with kidney at the base of symptoms and signs only. So laboratory studies are of great importance in kidney diseases. What are diagnostically important questions in taking history in case of nephrologic patient or suspicion on kidney disorders? It's important to check not only clinic events connected or directly and indirectly with kidney damage, but ask him or her what are medications they used or ever taken. Ask your patients about BP, blood pressure level, pulse rate, fluctuation of weight during the day, because fluid retention is possible and even typical for some kidney pathology. Daily consumption of fluid must be detailized too, and the volume of excreted urine is informative, and patient can suspect at least a marked change in these symptoms. And clinical diagnostics, symptoms and signs. How to collect all the principal points in one slide. Let's try. We are discussing kidney pathology, symptoms and signs. They are hematuria, edema, and hypertension. Of course, the signs of another diseases when kidney pathology is a part of the great systemic problem is possible too. But let's detailize. Hematuria, the presence of red blood cells in urine, edema, and hypertension are the key points in diagnostics of kidney disorders. A clinical example to illustrate these dry words by real clinical situation. Assume to your imagination. The typical patient with acute glomerulonephritis, for example, is a boy, young boy, who suddenly develop edema of eyelids and face edema. The color of urine will be changed. It can be reddish or dark. The BP will be increased too. So the classical renal triad in acute glomerulopathology is supplemented with oliguria limited by 500 milliliters per day volume of urine. So when you ask patient about retention of water, what's the volume of daily intake? Do you remember this questioning to be more informative? It reflects oliguria or contrary polyuria. As oliguria means 50 to 500 milliliters of daily urine, polyuria means enlarged, increased volume, a liters, more than 2 liters per day. But polyuria must be interpreted in connection with the daily intake of urine. In addition, person with acute glomerulopathy develops edema, most expressed in the face, most marked in the face, because of each morning anybody will investigate his or her face in the mirror. So it will be informative for patients, first of all. And in addition, hypertension or elevated BP will be added to these clinical signs. What do you think? If hypertension can appear in cardiovascular disorders, as we discussed in previous lecture, as edema is possible either in heart failure or in kidney disorders, what's the most informative diagnostical method? Imaging study, lab study, maybe procedure, your versions. Unfortunately, that's extramural lectures. That's why I answer instead of you, lab study. Of course, urinalysis, the first place diagnostical method, the gold standard in suspicion on kidney disease. By the way, this study includes more than 20 indices and must be prescribed to any person who is hospitalized in clinical department. But in our case, discussion of most informative tests for previous boy with acute glomerulopathy, of course, urinalysis will support, will reveal the most diagnostical information. Let's discuss proteinuria. So urinalysis includes plenty of indices, and proteinuria is not the first, but let's start since it. It means the presence of proteins in urine. You watched the movie before we'll start to discuss it. And you remember that proteinuria is possible. But pathologic one, diagnosed when more than 0.033 gram per liter or more excreted in patient's urine. So the border level, the upper reference range is 0.033 gram per liter. If more, proteinuria marked as pathologic. In case of glomerular pathology, non-specific proteinuria is typical because of increased permeability of basal membrane for proteins lead to non-selective appearance of all the proteins, large molecules, small molecules, all of them appear in the urine. So in case of glomerular pathology, proteinuria will be non-selective. If proteinuria is so high, then that 3.5 gram of protein appeared in daily urine, it will lead to specific disorder at the biochemical level and correspondingly with the clinical side, the so-called nephrotic syndrome. Look, how many proteins are in your student's blood or in the teacher? You remember 65 to 85 gram per liter. Multiply this quality per 5 or liters of the blood, and you'll see that 3.5 grams is a gigantic level of proteinuria. That's why that's serious disorder, and it can be detalized at the background of urinalysis too. In case of tubulopathy, proteinuria became selective because only small molecules can be reabsorbed at an appropriate level in tubuli. So, in glomerular membrane disorders, all the content from all the proteins from the plasma can appear in urine. So it will be non-selective proteins. In case of proteinuria, due to tubular pathology, reabsorption will be damaged. That's why small proteins which appeared in urine physiologically through the glomerular basal membrane won't be reabsorbed at the appropriate level. So it will be associated with selective proteinuria. Casts. Specific findings in urine in case of high concentration of red blood cells. Casts will be erythrocytic. High level of leukocytes, white blood cells, leads to leukocytic casts. That's logic. Hyaline cast can be revealed in very concentrated urine in case of fever, after physical exercises, after diuretics, after usage of drug, which provokes the high volume of urine excretion, diuretics. Next finding, hematuria, the presence of red blood cells in urine. In case of glomerular pathology, hematuria, red blood cells in urine, are of a great diagnostical value. One component among thriad typical for glomerulopathy. Not only glomerular pathology, but for example, urolithiasis, the stones in urinary system, can produce hematuria too. Leukocyturia. The presence of leukocytes is limited by isolated 2 to 3, 2 to 6 per field in microscopy, correspondingly for male and female patients. But if we are discussing pathologic, it must be more than 6 per field for women and more than 3 per field for men, correspondingly. And if the level of leukocytes is more than a half of field, they covered not less than 50% under microscope of this field. It can be named as pyuria. Bacteria in the urine. Bacteriuria. They are typical for infections. For example, pyelonephritis is diagnosed in presence of bacteria, and in addition, as a rule, it will be accompanied by leukocytes as inflammatory cells. And what do you think? What was listed before? Proteins. So infection, inflammation in tubuli will manifest with the proteins, selective proteinuria, then bacteriuria, and leukocytes, leukocyturia. Urinary syndrome is that very pedestal which diagnosis of all renal diseases is based upon. No pathology of kidneys is possible without changes in urinalysis. Even if the current investigation does not reveal pathology, one sample won't exclude kidney pathology and won't confirm too. That's why any pathology of kidneys must be realized in change in urinalysis. Which principal symptoms, conditio sine qua non, are typical of renal and urinary diseases? Let's vitalize this Latin sentence. Conditio sine qua non means the obligatory findings which must be revealed in any disease. Without these signs or lab studies finding, we can't prove the diagnosis. So, what are main symptoms typical for renal disorders? In glomerulopathy or glomerulonephritis, you can even write it because of during our future communication we'll interpretive lab studies, and these criteria are very diagnostical. So proteinuria, hematuria, and casts. This is specific for glomerular nephritis. By other words, we can reflect nephritic syndrome in this case. Pyelonephritis will manifest with a triad: selective proteinuria, bacteriuria, and leukocyturia, as I discussed before. Look, it is summary for each type of discussed pathology. Let's return to previous slide. If glomeruli damaged, it will be non-selective massive proteinuria, hematuria, and casts. In case of tubulopathy, such as pyelonephritis proper, it will be selective, less expressed proteinuria with small proteins only, bacteria in urine, and leukocytes. This triad is diagnostical too. So look, if anybody, any doctor or future dentist suspected tubulopathy or glomerulopathy, he or she can prescribe this urinalysis. And then, if you have found these results, that's quite confirmation of pyelonephritis. In our case, for example, you see the diagnostical value of this simple, cheap, available lab study. Such terms must be discussed in addition. Isostenuria means small deviation in urine density. So specific gravity of urine won't be changed properly as it's typical for physiology of human body. So isostenuria means monotonous specific gravity of urine without normal daily changes. How to check the function of the kidneys? And here is the question appear. What's the main function of kidney? Of course, excretory function. Plus water electrolytic balance too, but let's start since excretion of waste products, yeah? How to check? Is it good or bad function? The simple approach is to measure creatinine level. And now I'll ask you, if patient has bad function of liver and the waste products won't be excreted properly, they'll accumulate it in the blood. That's clinical thinking, yeah? That's logic. Look, where should you check creatinine level? In the blood or in the urine? What do you think? 1, 2, 3. In blood, because it will be increased in case of bad excretion of the same waste products. You see? So, to check good excretory function or bad excretory function kidney has, you should check the level of biochemical agent creatinine in the blood, as this creatinine is filtrating only. So neither absorption nor secretion won't influence its level. That's why to check glomerular filtration, that is excretory function, you should check bloody creatinine. In case of renal failure, it will be increased level of serum creatinine is more than 0.177 millimole per liter. Another helpful index is blood urea nitrogen. Less exact, but informative too. The main criteria of good filtration and corresponding excretory function is measurement of glomerular filtration rate. and it's counted by creatinine clearance. Specific formulas exist in books, internet, in professional sites and sites for patients. How to check glomerular filtration rate, GFR, by creatinine level. The investigation is the same. You should measure creatinine level, blood creatinine in patient, and then input it into formula. It will be counted and you'll get glomerular filtration rate level. Another studies to reveal kidney pathology are accompanied with visualization of kidney. What's this? Let's detailize. So first, renal sonography. Ultrasonography is the pedestal among all the imaging studies here in this area of internal diseases. Most frequent, cheap, relatively cheap, available. No any preparedness for this method. It can be done without severe preparedness per days and weeks. What can you see by this method? Size of kidneys, the density of parenchyma to suspect inflammatory, non-specifically, and maybe tumor, neoplastic changes. Then presence of both kidneys, because sometimes that's only kidney in the patient. Then some abnormality of morphology, structure abnormality can be excluded or proved. Then glomerular sclerosis can be suspected by ultrasonography. Of course, to be sure in character of any tissue in 100% reliability, you must perform morphologic investigation, cytologic one. But preliminary diagnostics of glomerular sclerosis is available by ultrasonography with the increased density of tissue and diminished volume of organ. Ultrasonography can help to reveal, for example, polycystic kidneys. Cysts are forming in kidneys and it can be seen by renal on renal sonogram. Then, in case of urolithiasis, it will be first step and gold standard method to reveal stones. I'll prove it by next slides when I'll show you the sonograms. Then, efficacy of treatment of urolithiasis can be proved by sonography again. And in case of tumor, the presence and localization and the size can be suspected by sonography too. So let's look. Left part is a scheme of kidney, such as student's kidney, yeah? And right side is visual pattern, which can be seen with a sonogram. Look at this. I won't insist on the details must be learned during the searching of this slide, of course. No, I'd like to show you the abilities of this method. That's quite informative. Look, you have no experience in this sphere. You didn't learn renal sonograms before, but you can see parallels between structure of kidney and its placement, size, structure. Key points of morphology can be seen, yeah? Cortex, medulla. And so let's look next slides and try to reveal pathology there. This is a informative slide again to see the placement of organ and division, schematic division into parenchyma and tubular patch, renal pelvis. You see, cortex is rounded by reddish color, yeah? Pyramids are between cortex and renal pelvis. And this is improvement of ability to measure kidneys, yeah? Ultrasonographers during performing of this method can measure organ, and it will be much more informative than attempt to diagnose it by palpation, not possible in any cases, and the same. So quite informative, yeah? And here you can see the high density finding. This is stone calculus, you see? Not very pretty, I am agreeing. So it was the hard slide, and now it will be easier to interpret in slides. Look, an arrow indicates gigantic stone here, and this one, yeah. And this is cortex, you see? The parenchyma, pyramids are here, and this is enlarged space due to the so-called hydronephrosis, enlargement of due to stone accumulation. Then, look, ta-dam, a plenty of stones can be seen in this area. You see, these white areas means high density findings. So in this space, in this projection, we can see multiple stones, but there are they small, yeah, and here is one large, another one too, but won't decline. And this is the same, not same, maybe from another patient, but this is stones with a diameter near a centimeter, which was eliminated spontaneously without additional procedures performed by a doctor. So this is urolithiasis. And look, only one diagnostical method is necessary to prove exact diagnosis. If you send the patient with suspicion on the stones in the kidneys, the only investigation, the only study will lead to correct diagnostical opinion. And that's valuable. Do you agree? Next slide. This picture illustrates the ability to diagnose stones in kidney urolithiasis. Yeah, not only the fact of presence, but the size, and correspondingly the size the doctor will solve how to treat this disease. So this method not only support the diagnostical abilities of the doctor, not only allows to put diagnosis of urolithiasis, for example, but also can help in therapeutic procedures choosing. Yeah, it can be endoscopy with ability to eliminate small stone, or not, contrary to this, it can be recommended attempt to dissolve the stones with the change of chemical media in the kidneys. So it's helpful not only for diagnostics, but for treatment too. How to treat, that's helpful to use later. Next method. Isotopic renography. It reflects the function of kidney, not only to see, but to check how does it work. So in chronic diseases, it can help to consider the saved or disordered excretory function by excretion of isotopes. Moreover, in obstruction by stones or in other causes, for example, tumor, it will be helpful too. It will show the level of obstruction, the ability to restore permeability of excretory system. So let's look to the pictures. So isotope was inserted into the patient's body And as a result, we can see the accumulation of this isotope in projection of this organ, and then step-by-step elimination. Yeah, kidneys, what's this? Guess, I won't answer. And excretion, you see, after 2 hours, then quite a 3 hours, this sample, yeah, and then 19 hours after injection of isotope. Distribution of isotope is informative, and the speed of excretion can be proved by repeated control. Another example, you can see kidneys due to accumulation of specific chemical agent, and it can be compared to the size, the function of accumulation of this isotopic, and activity of excretion. Look, these two lines reflect the function of each kidney isolatedly. Yeah? So I won't detailize, but the informativeness of this method is connected with the ability to consider functional ability of kidneys and divide what's wrong with the left or with the right kidneys, yeah, or with the both. Left picture is magnetic resonance image. Yeah, this is aorta. This is a right kidney. This is a left one, and this is a cortex of this kidney. Right, and this is a right kidney, and this is a left kidney, correspondingly on scintigraphy. Intravenous urography or pyelography. This method traditionally used for diagnostics of tubulopathy and diseases of excretory part, urolithiasis, and the same. But now, quite all the abilities of this method are substituted by ultrasonography. So this method is less accurate, but sometimes can be used to diagnose kidney diseases. CT. CT scan is informative in cases when ultrasonography can't answer all your questions. The resolution, the abilities of resolution in CT, of course, much higher than in case of sonography. That's why if you suspected pathology, but results of ultrasonography, that's not enough to be sure in pathology. Develops the diagnostical search with CT. It allows to visualize small tumors, limited in value, damaged along all the parenchyma of kidneys and the same. So this method is the second step after ultrasonography, if not enough, by other words. Look, so pretty picture, yeah? I'll remember you that legs are here, they are directed to us, and patients is at the back. This is spinal column, and you can see right kidney, left kidney. Other abdominal organs can be seen too. They are written for you. So to be able to interpret the results of CT, you should get a great experience later during radiology classes, then later on. But at least right now, we can consider the resolutionary abilities of this method, yeah, much more than ultrasonography. And in addition, it can be performed during different levels. So we can compare upper, lower part of kidneys corresponding to the level of performing this even. You see this one and this. Contrast enhanced CT is very informative. It can allows to visualize excretory potentials of any kidney. Yeah? And look, right one, left one, and again right and left. An arrow indicates the kidney stone. But I'll ask you as a future professionals, look, does it mean the only approach to diagnose stones? Is it the best step to diagnose? Stone is large, yeah, comparable with the, I don't know, diameter with the size of processus spinosus, yeah, quite large stone. Is it the only method? Only CT can be helpful? Of course, no. I think this stone can be seen on renal ultrasonography as before. But we don't know what's the indication for this investigation. Maybe it was another purpose except to visualize stone. That's why the only is evident. That's quite informative. What's this? An arrow indicate. Hmm? You see? Kidney, left kidney, and high density stones. And contrast enhanced investigation can allow to see excretory function in details. And who can count how many kidneys are here? One, two, three. Unpredictable situation. That's possible. I predisposed, I promised that medicine is very interesting. So, three kidneys, yeah? Look. Hmm. Look, there are no contra-enhanced addition to the method, but it can consider the inflammation of kidney. I won't explain you the science. It's available for experienced eyes. But look, I'd like to stress that inflammation and enlarged size of kidney, changed density of kidney parenchyma can be seen by this method. Another visualizing methods are magnetic resonance image when CT is not informative, either alternative to CT scan, and the contrasting of arteries or veins, correspondingly arteriography and phlebography. Both these methods are exact, quite expensive, but very informative. This is normal renal anatomy. You see, they are normal. No pathology. Next. The same renal measurement as we saw on ultrasonography can be realized in magnetic resonance imaging. Purifying of pathology of kidney. This kidney has no normal structures as the left one. This phenomena when there are no appropriate morphology in organ named as agenesia. A gold standard to diagnose glomerulopathy is punct biopsy, lab investigation of biopsy specimen to verify not only presence of glomerular pathology, but also the type of disorder, the treatment, the complications or stage if tumor diagnosed. So plenty of options are realizing by investigators of biopsy specimen. Confirmation of diagnosis of glomerulopathy. Look, only parenchyma should be investigated by biopsy. Prognosis, checkup of dynamic if treated, and correction of the treatment or choosing of the best one. What are typical investigations for glomerulopathy. Urinalysis, as we discussed before, and I'll reproduce again because repetitio est mater studiorum, that urinalysis in glomerulopathy will contain hematuria, proteinuria, and casts or cylinders. That's possible too. Then daily protein excretion. If more than 3.5 gram is nephrotic syndrome. And this is a phase of typical nephrotic patient. If you met such patient, what do you think? What's the most informative question? Let's recollect. What should you ask? If complaints, it must be indication on appearance of this edema at morning, then presence of hypertension or high BP level. It's realized if patient didn't measure BP yet with headache, vertigo, dizziness, photopsia. In Russian therapeutic school it named as insects before eyes. Technically, that's disorder of cerebral circulation realized in reversal disorder of vision. So, signs of hypertension are headache, dizziness, photopsia, sometimes nausea. And what's the main investigation recommended for this person if she has edema that's evident? And she complains on headache with some disorder of vision, with sometimes nausea, and decreased volume of urina, she said. What to do? Prescribe for. Of course, lab diagnostics. Of course, it will be urinalysis. Next lab study to be discussed today is complete blood count, the king of lab studies among routine list in any clinical department. It started since blood investigation. So, this is standard test with a plenty of criteria, and I'll speak about disorders at the level of complete blood count with the possibility of disorders of anemias and leukemias and other diseases of blood system. But now I'd like to stress some technically important points to diagnose kidney diseases, some endocrine disorders, and the same. So, results of CBC, they include information to prove diagnostical opinion of the doctor. For example, patient has inflammation. Can it be proved by CBS? Yes, I'll explain how. In CBS, leukocytes formula is included. There are some different forms of white blood cells. Their professions, yeah, neutrophils, lymphocytes, eosinophils, monocytes, all of them can be counted, and their ratio, their level will help doctor to speak about pathology of organ or system. The principal point is ability to suspect inflammation, as we said, and infection-associated process based on CBS result, on leukocyte formula. Anemia, this word was pronounced many times near you since your childhood, you had it. And what does it mean technically from professional point of view? If trust to the Greek term anemia, it means the absence of blood. Of course, that's not true. That's traditional name of this phenomenon. Really, anemia is a clinical and hematological syndrome which characterized by a decrease of hemoglobin per unit volume of blood with or without decrease of red blood cells. Look, the key point is clinical and hematological syndrome due to decrease of hemoglobin per unit, maybe with corresponding decrease of red blood cells. It leads to hypoxia, oxygen deficiency at the tissue level. Look, if you suspected anemia, what's the best diagnostical study? Of course, CBC. That's base of diagnosis, and it will reveal low hemoglobin and red blood cells. Excuse my mistake in frames, please. I didn't mark it. Let it be. Lab study which can help you to reveal inflammation. Of course, inflammatory symptoms in science will be founded by the doctor on examination. But how to prove the presence of inflammatory process in human body if not evident? And how to consider the severity of inflammation? CBC will help you. Triad typical for inflammation must be learned by any professional in medical sphere. That's actual for your work later in oral cavity too. So, inflammatory triad includes leukocytosis, shift to the left, and increased ESR. Any inflammatory disease, glomerulonephritis, rheumatic fever, arthritis, cholecystitis, much of them end at itis, but it's not 100% reliability. Not all the diseases end at itis mean the presence of this triad. But in general, the strategy is the same. If inflammation exists, you can find leukocytosis, high level of white blood cells, young cells in great percent, and increased erythrocyte sedimentation rate. Leukocytosis means the level of white blood cells is more than 9 multiplied by 10 in ninth degree. Increased level of leukocytes is typical for example, pneumonia or any other inflammatory problem. Shift to the left means the high percent of young cells. I know you like the hematopoietic scheme, but I do not post it in my presentation. But if you remember hematopoiesis since physiology, you must recollect the steps of growth, of cells. Since first class, then second one, unipotent cell, polypotent cell, then unipotent. And when we are discussing left shift, it means the high level, high percent of stop cells, young soldiers, in peripheral blood. In norm, their content is less than 6% or is 6%. If stop cells is more than 6, it indicates shift to the left. Young forms appeared in blood flow. And the third compound is increased ESR. Erythrocyte sedimentation rate is third non-specific sign of inflammation in CBC. Another test, biochemistry, they allow to evaluate, for example, electrolyte content, enzymes concentration. So quite any biochemical agent can be measured in human body to make conclusion about hyperfunction of organ is producing this one, or disorder of metabolism, or excess of accumulation, disorder of elimination of any product. I won't list all the possible agents because there are decades, hundreds. But I'd like to stress in frame of kidney disorders that protein level measurement in blood is principal. The toxic metabolites products are informative to be measured too, as an illustration of decreased excretion, decreased excretory function of the kidneys. Do you remember creatinine? This is the same situation. Creatinine measurement will be informative to check the glomerular filtration rate, as Miss said. This is a good example of biochemical testing. In case of CVS disorders, for example, if you remember, atherosclerotic plaque is forming. And in case of atherosclerosis, total cholesterol is increasing. It's more than 5.3 millimole per liter. So high total cholesterol indicates the risk or presence of atherosclerosis. So any suspected pathology of internal organs can be tested with a specific combination of biochemical tests. It depends from the system or organ which is damaged, or with the severity of the disease, or the type of it. So it will be limited by choice of the doctor and necessity to prove diagnosis or detailize the course or severity. Who knows what's necessary to measure in case of liver diseases? If patient develops such sign as jaundice, his clear eye yellowish, what's increased? Do you remember biochemistry department? Of course, bilirubin, direct and non-direct. So this is a real clinical usage of these biochemical knowledge. C-reactive protein. I'd like to stress it because that's important, or inflammatory or autoimmune or even oncologic disease marker. This protein reflects activity of the disease. The more expressed inflammation is, the higher level of C-reactive protein. So this lab study is informative to suspect, to prove the stage or activity of inflammation. And here the face of the same girl, as we saw before. I spoke about necessity to measure, to check urinalysis in her, but taking into account such expressed edema and hypertension, as I said, we must choose some biochemical tests. What are they? They are albumins in the blood. So proteins in blood must be measured, and albumin proper. If level is less than indicated here, it will be confirmation of nephrotic syndrome. Then, by definition, nephrotic syndrome is developing when urine protein excretion is more than 3.5 per day. You see? So, you should measure protein excretion in daily urine. Then, if protein concentration in blood is very low, the synthesis of cholesterol became higher. So next biochemical agent is cholesterol. You see? Other signs listed here are typical for patients with nephrotic syndrome. Severe proteinuria is more than 3.5 grams per liter will lead to decreased level of proteins. And as a consequence, hypoproteinemic edema with such expressed eyelid edema and general face edema, all the body edema, anasarca, will be developed. So look, this slide informs you about connection between clinical signs and edema. And lab study need to confirm this opinion. That's why diagnostical abilities in nephrology and in internal diseases at all are not limited by symptoms and signs only. In addition, imaging studies and lab study must be added to the list of all the necessary examinations. And some words about endocrine pathology. What's at the first place? What's the well-known by patients and doctors and future dentists? Of course, diabetes mellitus. The problem of feedback. So, some words about functional anatomy. You remember pancreas, you remember islet of Langerhans, I hope they, and two main classes of endocrine cells, insulin-producing beta cells and glucagon-secreting alpha cells. Beta and alpha cells change their production of hormones correspondingly the demands of the human body. This is a stable, not stable, this is dynamic balance to correct glucose level between physiological ranges. Yeah? So their secretion is defined by necessity, by demands of the human body in the same time. After food and the fasting, after physical exercises, and the same. This is a dynamic balance between glucagon secretion and insulin production. In case of diabetes, insulin can't be secreted at all, either absent or its secretion is impaired, and the so-called insulin resistant is formed. As a result, the main universal end of this phenomena is high level of glucose in the blood, hyperglycemia. So, absence of insulin or disorder of secretion and realization of its effects leads to hyperglycemia, the universal sign of diabetes mellitus. There are two types of diabetes. I won't detailize them, but they include, first, primarily absent of insulin, so no insulin as necessary, or extremely low, or at all, no insulin. And second type is characterized by irregular, incorrect susceptibility to insulin, by receptor disordered, by resistance to this hormone, and the same. So inversion of sensitivity will lead to secondary insulin resistance and as a consequence hyperglycemia again. How to diagnose? The level of glucose. This is a variant of disease as diagnosis is based on the one investigation only, glycemia, or level of glucose in the blood. Of course, not one sample, but one method is necessary to prove it. There are lab criteria. How to interpret a lab study? You can. Diabetes is verified if 2 times we proved the presence of 11.1 millimole per liter of glucose and 2 fasting serum glucose is more than 6.66. 6.1 is a high point of reference range of insulin for healthy. So if more than 6.66, 2 times fasting levels, it will be considered as diabetes. In our therapeutic school, by the way, we prefer use millimole per liters. Somewhere milligrams per decaliters are used. That's why to convert each to other, no problems. You should multiply the value by 18. So if you multiply each listed level per 18, it will be milligram per deciliter. What are signs of diabetes? Hypoglycemia will lead to osmotic diuresis. The higher concentration of glucose in the blood, the more urine will be excreted per day. So polyuria is very typical for diabetes mellitus. As a consequence, polydipsia will be developed. That's logic, because 4 liters of urine per day or 3 liters, it's much more than possible. And of course, due to thirst, patient will intake a plenty of fluid. So polydipsia is a consequence of polyuria. Correspondingly, polyuria is a consequence of high concentration of glucose, hypoglycemia. Another lab study, diagnostical one, is a glycation hemoglobin test. If the level of glucose in the blood, glycemia level, is informative right now in this time, hemoglobin HbA1c test, glycation hemoglobin, informed you about some time limited in time period. So prolonged correction of glucose level will lead to good results. No any increase of glycation hemoglobin. But if during some period of time it was episodes of glycemia, not now, not yesterday, but during some days or weeks, it will be increase of glycation hemoglobin test. Results of hypoglycemia are listed here. So, diagnostical methods for diabetes are of a laboratory values. So, they are fasting plasma glucose is more than 6.66 or more than 7 millimole per liter or higher. 2 times, you remember. And HbA1 hemoglobin level is more than 6.5. Let's model clinical case. Patient D, age 50, consulted a dentist about suspected oral candidiasis. In addition to the condition of the mucous membranes, he also complains on periodic thirst, dry mouth, especially after eating sweets, which he loves very much, frequent urination during the day, and very large volume of urine. Who do you suspect preliminary diagnosis? And what should you prescribe for to check yourself? Key points are stressed by Reddish. Very large volume of urine is polyuria, thirst, dry mouth, polydipsia, so diabetes mellitus, and check glycemia. Of course, this case is directly connected with my previous speech. That's evident. But if you met the person with the candidiasis of oral cavity, think about possibility of diabetes. This is a widespread disease, the problem of century. That's why try to think as a doctor and see not only your local professional area, but think about system disorders. if you help him to diagnose main disease, which led to local dentistry pathology, it will be helpful since systemic point of view. Your treatment will be much more effective if you, for example, plan to insert implants, for example. In case of diabetes, such procedure can produce severe complications. But if you and your patient will know about diabetes and he will control the cause of this disease, that's possible now. I'll show you the techniques some minutes after. It will be much more effective to treat him in frame of dentistry problems, you see, because of diabetes will influence of efficacy of your work. Think about it. For dentists, for future dentists especially, there are listed local manifestations of diabetes in oral cavity. Xerostomia, dental caries, gingivitis, periodontal disease, they are non-specific, of course. I'd like to stress the high risk of candidiasis in oral cavity. Not clear stomatology, not clear dentistry, but very remarkable by you. And repeated prolonged course of all these diseases, I'd like to stress xerostomia, in addition to candidiasis, they can help you at least to think about additional lab study, and maybe hyperglycemia will be revealed. And there are oral manifestations of diabetes. This is candida-related lesion. This is angular cheilitis, excuse me, glossitis, specific. You see? After the stomatitis. First, ask patient, have you diabetes? Second, recommend him to check glucose. This is a summary of this chapter of my lecture, since diabetes is a common disease and can have some annoying manifestations in the patient's mouth. It's important to demonstrate the so-called watchfulness about this disease. And it's enough to recommend one informative lab study. Now I'd like to show you the modern abilities to control glycemia level. Not only clinical departments or labs can help to the patients to check glucose level. It's possible to realize it not at home, but in any place. Please look.
Prepare your kit. You will need a meter, test strips, a finger pricker or lancing device, a lancet, cotton wool, and a monitoring diary to record the results. Step 1. Wash your hands first. Make sure your hands are thoroughly dry before starting the test. Load a new lancet into the finger pricker or lancing device. Snaps in there. Load a test strip. Into the blood glucose meter. This one switches on as you put the test strip in. Prick your finger at the sides as it's less painful than at the tip or at the pad, so prick it on the sides just here. Give a little squeeze. Not too hard. If you need to squeeze too hard, then take another test and prick your finger again. Just check the machine is on before you put the blood onto the strip. The result should appear within a few seconds. And there we go, it's a little bit low, 3.6. I'll need to treat that with some glucose tablets. Just clean your finger, clean the blood off the fingers, remove the test strip, which can be thrown away, and make sure that the lancet in the machine is disposed of in a sharps bin. Finally, record your results in a blood glucose monitoring diary, as I have here. That's 3.6, and that's after lunch.
Let's continue with another studies. So, bacteriological study. It allows to reveal the causative agent of the diseases and sometimes check the sensitivity of the pathogen to antibacterial drugs, so it helps to choose the treatment. Morphology or morphological study of tissue biopsy specimen. This is of sphere of pathanatomy department. So, as a clinician, I'd like to stress the importance of this investigation to exclude tumor, to characterize, for example, type of glomerulopathy, if glomerulonephritis suspected, and biopsy was performed to verify it. Another study, lab study, of course, connected with respiratory system, first of all. But I'd like to list it among all the available lab studies without direct connection with the today's topic. So, in some diseases, this examination is valuable. For example, in case of TB, this investigation will prove the presence of mucobacteria, that's diagnostical point in TB search. In asthma, the typical Triton sputum is eosinophils, Charcot-Leyden crystals, they are destroyed eosinophils, and Kurtzman spirals. So, by other words, this is a triad in non-treated asthmatic patient, which helps you to prove your first diagnostical opinion. In infections such as pneumonia of respiratory tissue, a different pathogen can be seen visually, but proved then later by previously named bacteriological investigation. The visual examples are here. There are Charcot-Leyden crystals in person who has bronchial asthma. These are this. And there are mucobacteria. TB is detected if such pathogens are met in sputum sample. Diagnostical method in endocrinology can't be limited by diabetes mellitus only. Let's discuss another organ connected with endocrine system. What is it? You see. And before we start to discuss diagnostical abilities, let's recollect your knowledge in physiology and functional anatomy to make your life easy in interpreting of lab studies later on.
Thyroid hormones, function and feedback. When the neurosecretory neurons of the hypothalamus secrete thyrotropin releasing hormone or TRH, This TRH travels down to the axon terminal of the neurons, where it is released to enter the hypophyseal portal system of the brain. This hypophyseal portal system is essentially a bridge between the hypothalamus and the pituitary gland, particularly the anterior portion of the pituitary gland, passing through its network of capillaries to reach the anterior portion of the pituitary gland. In the anterior pituitary, the TRH binds to receptors on the endocrine cells within the anterior pituitary, stimulating the endocrine cells to secrete thyroid stimulating hormone or TSH. The TSH eventually enters the systemic circulation, ultimately reaching the cells of thyroid gland. In the thyroid gland, the TSH binds to receptors within the gland, thereby secreting the thyroid hormones triiodothyronine or T3 and thyroxine or T4. The difference between the T3 and T4 hormones of the thyroid gland are as follows. 1. T3 has 3 iodide molecules in its structure while T4 has 4. 2. Although T3 is less prevalent in the body than T4, it exerts a much stronger effect on the body than the latter. When T4 enters the systemic circulation, it gets converted to T3, which exerts the following effects in the tissues. 1. It increases the number of mitochondria within cells. 2. It controls the rate of cellular respiration, or in other words, controls the metabolic rate of the cells. It accomplishes this by increasing the activity of sodium-potassium ATPase pump, thereby increasing the hydrolysis of all available ATP, resulting in an increase in the basal metabolic rate or BMR, as well as generating heat as a byproduct of this process. All this creates a need for more ATP, which is mobilized through the energy stores of the liver and skeletal muscles through glycogenolysis, the adipose tissue through lipolysis, and the breakdown of skeletal muscles to amino acids through proteinolysis, thereby providing substrates for cellular respiration. Thus, thyroid hormones contribute to 1. The growth and development of the body's tissue. 2. Creates a balance between the catabolic and anabolic reactions of the body. Increased T3 and T4 levels in the blood results in the hormones binding to receptors in the hypothalamus, thereby blocking the release of TRH or inhibiting the responsiveness of the anterior pituitary to TRH, thus creating a negative feedback which inhibits the rising levels of the thyroid hormones in the blood.
Look, that's why you see this film to recollect the activity of some hormones. And when we should to diagnose function of thyroid, what should you check? Of course, level of T4 and T3 as the main products of this. A negative feedback will lead to inversion between the level of T4 and T3 and thyroid stimulating hormones. But let's start since clinical science with the example of decreased function of thyroid. Decreased function of thyroid by definition means low level of T4 and T3. What are signs? They are listed here. Decreased metabolism will be associated with hair loss, fatigue, loss of energy, weakness, sleep, along all the days. Bradycardia, decreased heart rate, is less than 60 per minute. Weight gain due to disorder of metabolism. High level of cholesterol is typical too. Constipation or tendency to constipation is typical. Dry skin, hair, all these signs are their collection will help you to suspect some disorder of thyroid. They are typical for decreased function of this organ. How to check it? This is an answer. Lab study are of the main approaches to prove high or low function of thyroid. So, thyroid stimulating hormone is in inverse ratio to T4 and T3. The higher level of thyroxine and 3-iodothyronine, the less level of thyroid stimulating hormone. That's typical for hyperthyroidism. But our woman suffers from possibly hypothyroidism, so she will have high level of thyroid stimulating hormone and correspondingly low level of thyroxine and 3-iodothyronine. All these levels must be investigated in complex. The recommendation is to prescribe all three, maybe with a fourth level of 3, T4 and T3. But first approach to disclose the function of thyroid is to check T4, T3 and TSH. This biochemical investigation of blood is very informative and can help you prove your opinion about decreased function of thyroid. Unfortunately, we limited in time, but I hope that our dialogue, virtual, of course, due to extramural lectures, will be helpful, and at least some points or some first impression was get after these introduction lectures. Later on, we'll discuss each disease in more detailed script. So, this general approach informed you about possibilities of physician to make diagnosis. All these parts of clinical examination, including symptoms and signs, taking history, objective physical examination, including inspection, then additional studies show you the wide spectrum of diagnostical abilities in clinical medicine. So, thank you for your attention. I'll meet you next time with internal diseases lectures devoted by pulmonology or respiratory diseases. Best wishes and goodbye.